Hello, my name is Liz Beverly, and today I'll be talking to you about psychosocial concerns in adults with type 2 diabetes. The objectives for today are to describe the three most common psychosocial issues affecting people with type 2 diabetes and to review evidence-based treatment guidelines for psychosocial issues in people with diabetes. There are several psychosocial factors that interfere with recommended self-care and are associated with higher hemoglobin A1C values. And the three most common are diabetes distress, depression, and anxiety. Diabetes distress refers to the negative emotional experience of living with diabetes, and it's important to note that it is not a proxy for depression. Now, some of you might not have heard of diabetes distress, and that's because it's not a psychiatric diagnosis, and you won't find it in the Diagnostic and Statistical Manual of Mental Disorders. However, it's important to know what diabetes distress is, because as you can see here, 42% of adults with type 2 diabetes report significant diabetes distress. So what is distress? Well, diabetes distress refers to a person's frustrations with self-care, worries and concerns about the future with developing complications or being able to afford their medical care, fears in general about living with a demanding and progressive chronic illness. It's important to note that diabetes distress is associated with higher A1Cs, performing less self-care behaviors, increased risk for both microvascular and macrovascular complications, decreased quality of life, and it's also associated with increased mortality rates. So what does the American Diabetes Association recommend? Well, they recommend screening at least annual for diabetes distress. And if people aren't meeting some of their glycemic goals, or if they're going through a major transition such as retirement or moving, a new job, a divorce, they recommend that screening at a transition time. And if someone is newly diagnosed with a complication or the complication has advanced, to screen for diabetes distress then. Now, once you screen, if you screen and there's a positive screen for high and severe diabetes distress, what can health professionals do? Healthcare professionals can address diabetes distress in the medical visit through providing diabetes education. You can also do it through behavioral change approaches, such as motivational interviewing. Now, as a healthcare professional, if you notice that you're giving education and using motivational interviewing, but you haven't noticed any improvements in 3 months, that is a good indication that you should do a referral to a behavioral health professional, ideally one with experience in diabetes, for additional assessment and treatment if indicated. So what is the ideal screening tool for diabetes distress? I recommend using the Diabetes Distress Scale. This is validated in adults with type 2 diabetes. It's 17 items, and it measures very specific domains of diabetes distress. So it can measure emotional burden, diabetes interpersonal distress, physician-related distress, and regimen-related distress. So by having people fill out this diabetes distress scale, you can actually see what their source of diabetes distress is, and then you can tailor your education and your conversation to the different sources of diabetes distress. Moving on to depression. We all know that depression is more common in people with diabetes, and it's also elevated depressive symptoms as well as major depression. And the rates are very high. So you can see clinically relevant depression symptoms and major depression affecting 1 in 4 people with type 2 diabetes. It's important to note that the adult prevalence is about 25% in people with diabetes, or if you're looking at the general population, it's only about 11%. It's also important to note that there is a difference observed by sex. You can see that the 28% rate of major depression and clinically significant depressive symptoms in women compared to only 18% in men. Why is this important? It gives you indication for who you should be screening for. It also points out that this is a major issue, and it's a major issue because depressive symptoms and major depression negatively impact self-care as well as A1C levels. And impacting self-care and A1C then in turn can have an impact on microvascular and macrovascular complications. It decreases an individual's physical functioning. It increases hospitalization rates, and research has also shown an increase in mortality. I do want to point out that depression and diabetes has a bidirectional relationship, which means not only can diabetes cause depression, but depression can also cause diabetes. So you can see here, there's a lifetime history of depression. It increases someone's risk for type 2 diabetes by 38 to 60%. So this tells you if you have patients in your primary care or specialty care who have depression, it's important to keep note and also to make sure that you are doing screenings for diabetes. And it is believed that it's the activation of neuroendocrine and inflammatory responses that induce insulin resistance, which lead for depression to be causing type 2 diabetes. Also, the diagnosis of diabetes and then the responsibility of dealing with self-care and the risk and worries about complications, that in and of itself can lead to depression. There's some interesting research that has come out of a randomized controlled trial, which interestingly, part of this randomized controlled trial was conducted in Southeast Ohio. It was called Program Active. And here's some information to note about the number and duration of depression episodes in adults with type 2 diabetes. So overall, the number of lifetime episodes for major depression in adults with type 2 diabetes is about 2. The mean episode of duration for a major depressive episode tends to be about 2 years as well. And then if you look at the mean lifetime exposure to all depression diagnoses, you can see here it ranges in 43 months to 61 months. So it spans several years. And another important thing to remember is that episode length for major depression becomes longer with each subsequent episode of depression, and periods between episodes will become shorter. So if you have someone with a history of depression who has type 2 diabetes, it is a good chance they will have another experience with major depression. It may be a longer episode, and there might be a shorter duration between episodes. So this is why frequent screening is important. So we are all familiar with the 9 signs of major depression. These are the 9 signs that you will see in the Diagnostic and Statistics Manual of Mental Disorders. For someone to be diagnosed with major depressive disorder, they have to have a criteria of one of the first 2, either a depressed mood most of the day, nearly every day, or markedly diminished interest or pleasure in all or almost all activities most of the day, nearly every day, and then at least 4 of the associated features present for the symptoms 3 through 9. I do want to make a note that if you do look at some of these signs for diagnosing major depressive disorder, some of them also overlap with hyperglycemia. So it's really important to make note of that and to make sure that some of the changes that you're noticing aren't related to hyperglycemia. So what does the American Diabetes Association recommend? They recommend at least annual screening and more frequent screening among people with a history of depression. They also recommend screening at the diagnosis of a complication or when there are significant changes in an individual's medical status. When you do have a positive screen, they recommend that you refer your patient to behavioral health, ideally someone with experience in diabetes, and ideally someone who's using cognitive behavioral therapy. It has been shown that that is the most evidence-based, best practice treatment for depression in adults with type 2 diabetes. There's also newer research that is showing that if you can incorporate physical activity, if feasible and if able, into someone's plan, you can also improve depressive outcomes if someone is experiencing depression with their type 2 diabetes. So what recommended screening tools? Here are 2. I recommend using the patient health questionnaire, the 9-item version, and you can see that these correspond directly to that table that we just referred to on the 9 criteria for major depressive disorder in the DSM-5. I'm also including here the geriatric depression scale. So we know that type 2 diabetes is more common in adults over the age of 65. It's also important to note that depression signs and symptoms might be slightly different in older individuals, which is why there is a separate depression scale. So the geriatric depression scale is a 15-item measure that was developed to assess depression in older adults. And this has been validated in adults aged 55 to 85 years old. And lastly, we're going to talk about anxiety. There's about a 20% prevalence of generalized anxiety disorder in people with diabetes. So the lifetime rate is 1 in 5 people with type 2 diabetes will experience generalized anxiety disorder. Anxiety can impact self-care. It can lead to unhealthy behaviors such as smoking, unhealthy eating, and not performing physical activity. It's also important to note that you might have someone with diabetes who's worrying about their complications and hypoglycemia, and these worries can also lead to generalized anxiety disorder. And then, of course, if an individual has experienced a very severe hypoglycemic event, it is possible that they can develop post-traumatic stress disorder and or panic disorder because of that event. So what does the American Diabetes Association recommend? They recommend screening for anxiety in people with worries about complication, insulin injections or infusions, and hypoglycemia. So they say screen for anxiety in those who show anxiety symptoms. So anyone who's showing avoidance behaviors, perhaps excessive repetitive behaviors, or any signs of social withdrawal. And then what can a health professional do? Well, they can discuss their diabetes-related worries. If they feel that they're not addressing these worries sufficiently, they should consider a referral to a behavioral health, ideally one with experience in diabetes, for further assessment and treatment if anxiety symptoms interfere with their diabetes self-management behaviors and their quality of life. What are the recommended screening tools? I have 3 different tools here. The first one is the Beck Anxiety Inventory. This is widely used. It's 21 items and it assesses self-reported anxiety. I've also included a brief screener on generalized anxiety disorder. This is 7 items and it assesses the severity of generalized anxiety disorder. And then lastly, I mentioned that concerns about hypoglycemia are a major worry for people with diabetes. So if you have people with diabetes who are expressing concern about hypoglycemia, and this is particularly for people who are on insulin or on sulfonylureas, this is a 33-item survey that can assess behavioral and worry dimensions for hypoglycemia in adults. So to summarize, people with type 2 diabetes have psychosocial concerns, and they are more prevalent compared to the general population. These psychosocial concerns can interfere with a person's ability to carry out their self-care, and it can potentially compromise their health status, leading to micro or macrovascular complications, hospitalizations, morbidity, and even mortality. It's important that we address these psychosocial symptoms, even if they are subclinical in nature. And what we do is we recommend, along with the American Diabetes Association, that we do routine screening and then monitoring the psychosocial status of these behavioral health issues, and then refer to a behavioral health professional if indicated. Thank you so much.